Are starting today's session. Thank you for coming. Ramadan Mubarak again. And these are our new timings during the month, blessed month of Ramadan. And it's Pakistan 5 p.m. Here in New York time, it is 8 a.m. and Boston as well, from where our speaker Zafar Naqvi is from. So I will first ask Zafar to introduce himself and start the lecture, and then we can introduce the panelists and start the Q&A session. As usual, this is our pattern that Zafar will speak for some 15-20 minutes, and then afterward we will start the question answer session with the introduction of panelists. So with that, Zafar, please go ahead and introduce yourself and start.
Thank you, Shahid bhai. I'm Dr. Zafar Naqvi. I'm a psychiatrist and psychoanalyst at Harvard Medical School. I work here at McLean Hospital. I'm an addiction psychiatrist and also a special interest in eating disorders. For the brevity of time, I'm going to, I may be skipping some slides because they may be, more related to the US situation. So Shahid bhai, it has to be 20 minutes, or it can go a little bit over that?
It can go a little bit over. We'll see how, if there are more questions, I'll tell you. Otherwise,
Okay.
you can go for 25-30 minutes and
Okay.
speak a little bit louder, I think.
Oh, okay. Hang on.
Yeah, that'll be good. It's closer. Yes.
All right. So I'm going to share my screen now.
Okay. In the bottom, there's the share screen. If you click.
Yeah, I will actually,
Okay.
yeah. Can see the screen?
Right.
Which slides?
It's
Okay.
good. Yeah, it's good.
All right. So we'll be talking about COVID-related, mostly anxieties, but also the mental health problems. And this a disclaimer first. It is basically a non-Harvard presentation. I'm not presenting it for Harvard, and I do not have any other disclaimer or conflict of interest. So we'll be talking about some data later on, but we'll start with the problem that what we are facing as a human being, as a human fallacy. Everybody knows that as a human being, we tend to know everything. The certainty of the thing, the controllability of the thing. We don't like things as a human being which are uncontrollable and uncertain, and there is also a root of anxiety. And the COVID is basically coming with this kind of challenge that it is giving us the collective fear as a human race, collective grief, and that's on top of the catching the infection from the virus, but also uh, the whole social fabric is got affected by that. Uh, and there are differences between the other anxieties versus pandemic anxieties, and we'll talk about that as we go on. But uh, two things. One is that in other anxieties, you have a kind of a more individual experience. You're not that concerned about your loved ones unless you have an extreme OCD, which can. But usually, it is your own experience. But here is collective anxiety. So, for example, the recent poll suggested that there is increase in US population to have more mental health problems, which basically, when they're asked the specific question, they were more concerned about their loved ones. So this is the whole fabric of any pandemic. These are the stress associated with the pandemic, that you can see that some of our patients who have existing PTSD, they have these exposure to traumatic images, massive loss and grief. Now, some people who have unresolved grief, is also creeping up. Um, Community is with inadequate supplies and cascading economic problems, uh, inconsistent information. So it depends also that at what time you're getting the information and how much you're chasing the information, and it will have the impact on the anxiety, and we'll talk about it later on. Now, in addition to that, there's also stress with the mitigation strategy. So being in the quarantine, taking your temperature, right? Uh, Being separate from the family, thinking of your kids or your family, so all these and also the final rites, which basically it's been very challenging and very unfortunate that people who basically are dying from COVID, they have to depart this world before even meeting their loved ones. So this is very challenging situation as a human race. School dismissals, closing places. So like in Ramadan, religious congregations. So in other words, let me just take you to this slide, which we will see that what basically happening is, as mammals, we have some attachment needs. We are human beings, but we are also mammals. And the attachment needs have been challenged by this COVID. We have 5 basic attachments. And if you see this COVID is attacking all the attachment needs. So we have seen the deserted scene in the grocery stores. So the food, people are talking of stockpiling. The mind is receiving the this, is going into the panic stuff, right? These scenes, then people were looking forward towards having their marriages, wedding, functions gone. People were looking forward to our future, towards the kids' graduation. That's gone. And our belief, philosophy, religion, like Ramadan or different religion, those congregations are gone. Last but not the least, social attachment. So that's why we say that please change the name from social attachment to physical attachment, because if you change the name, that's going to give you your mind the message that you can still emotionally connect with your loved ones. So at least that part of your anxiety, separation, and anxieties and the attachment needs. So we need to come up with attachment solutions as human beings, as mammals, because this is our survival. So you can see that everybody is facing this turmoil and this whole new situation with blend of emotions, highly emotionally charged experiences. The other problem is that in this, so in any disaster, usually there is a time limit at the beginning and the end, and it has these phases that you can see: the pre-disaster heroic, which means that everybody comes for help, and then slowly and gradually they have to resolve that. Now, in pandemics, what happens? If you can see here, that is working through the grief. Everybody goes through this process in pandemic. Even in US, you never know when is the peak. In Massachusetts, in New York, in Dallas. So there is a space-time peak and surge. So that is compounding the problem more. So then by the time we go to the reconstruction and coming to the term process and working through the grief, it may be multiple chunks of time, which probably has been evolved, which can also affect our psyche. Now, if you look at the psychiatry in pandemic and non-pandemic, these are the challenges that we are facing as well. That in pandemic psychiatry, we more focus on population rather than individual patients. We are more focused in pandemic in the wellness of the community rather than like individual disease. More focused. So we are on both, but we do both. Prevention. We are looking for preventions. We are looking for leadership consultation. Now, when I say leadership consultation, I want basically I want to mention you guys. You are the leaders of your own organization, or even if you're working in a consult liaison service, you're a leader, and you have to navigate to how to manage your team, how to even disclose day-to-day informations in a calm way, in a way which will not demoralize your team. So leadership at that level, and then above from that. And then the health risk crisis, it's for the whole community, and this interlinked. I will come back to that a little bit later on. So the areas that as a psychiatrist we need to work on, you can see that there are certain emotions which sometimes we just ignore and or don't want to process or abandon them or just disown them. But these are the real problems, and I will give you some examples of my patients, how going through this whole pandemic, how the whole thing, even like two brothers that I treated, the whole thing changed, and I will give you an example about that. So this is the thing that everybody is facing: fear, anger. Now resilience slash altruism. Now in our society, like in Asian culture, I think this is also very common to put your own needs at the back burner and present yourself for help for your uh, uh, somebody who's ill. But that can also result into exhaustions and caregiver challenges. And there's unfortunately there's some studies in China. China is also like in Asia, which basically showed that the elderly population who actually passed away in the pandemic. Their main concern was, although they were afraid of catching the virus and they're ill, but they're also concerned that it's very high ranks that they don't want to burden their families. So the targets for intervention are the following: to work on withdrawal, isolation, loneliness, and alienation, emotional dysregulation. Now, emotional dysregulation can cause interpersonal conflicts, when intrapsychic conflicts can translate into interpersonal conflicts. Hopelessness, helplessness, fear. Fear is the least common denominator of any anxiety disorder. So, for example, if you have height phobia, you have acrophobia. If you're afraid of height, if you're afraid of closed spaces, you have claustrophobia. If you're afraid of social situation, you have social phobia. And if you're afraid of spiders, you have arachnophobia, and so on and so forth. If you have a fear of unknown, you have panic disorder. If you have a fear of contamination or putting things in order, you have OCD. And if you have fear for everything, you have generalized anxiety disorder. And you guys already know that, but I'm just trying to structure that in a way that we can move further in the presentation. Now, before going any further, we need to know also how to link the mental health with the physical health. So we know that excessive stress can compromise our immune system, and that can paradoxically can even make us more vulnerable to the virus. 2, cingulate gyrus. Cingulate gyrus, by default, that's the area in the brain above the corpus callosum, which receives the pain at the cortical level, and unfortunately, being human, by default, it cannot separate the physical pain from the psychological pain. So what is, in other words, if we have untreated depression or untreated anxiety, that can make our physical pain worse, and vice versa. If our physical pain is not treated properly enough, then it can make us more depressed and anxious. And then the telomeres, we know that they are the encasing at the end of each chromosome, and certain stressful thought patterns like rumination, catastrophization, and pessimism can shorten our telomeres. And what it does, basically, the stress of which can make us age faster and die sooner. So this is telomeres we are talking about. So with this being said, so we will expect these common reactions, and everybody is basically having these experiences. And let's examine some of it. And because of people locked in, there is a higher rate of in US, there are higher rate of divorces, domestic abuse, and intra-family violence, and all these, and also even for example, kids who have autistic spectrum disorder, they are also becoming hard to manage. So we all now expect to face this challenge, even when the lockdown is over, that you can have a resentment from others, monitoring yourself for others, job security, look for a new job, the basic human needs. So when we talk about, just examine few emotions so that we will know how important the emotions are. People use the emotion of guilt and shame interchangeably. However, they are exactly opposite of each other. They're both very powerful emotions. One is empowering, but the other is disenfranchising, and let's examine that. So guilt, if somebody is harboring the emotion of guilt, that can give that person power and purpose and meaning in life and hope to change the future. Why? Because he knows that he has done something, he can rectify a thing, he can make amends, and he can change his future. And his direction will be towards people. Versus somebody is harboring the emotion of shame, has no clue that what I have done. I mean, people are shaming, blaming me, and he basically further withdraws and goes into isolation, becomes hopeless, and his direction will be away from community or away from people, exactly opposite. So, and since we are talking about that, so I was treating two brothers, and both were having depression, but one's core emotion for with the depression was shame, and the other was the guilt. So the one who was actually facing guilt, he started to get better, but just pre-COVID, after just before the lockdown, and once he's locked in now, his depression got worse, and the brother who has predominant emotions of shame for his depression, uh, his depression is stable, or maybe a little bit better. So by knowing these interplay of these emotions, you can also inform your psychotropic medications treatment. Uh, Let me see. So now I will just touch. Anger is like whole 1 hour topic to talk about the anger, but a few things. I mean, people. If you ask somebody, do you have any anger problem? They say no. They deny, and by doing so, they're actually delaying the process of their uh, anger management, or to resolve or come to terms with those experiences which generated the anger in them. If you really put a D in front of anger, it becomes danger. So it's a one word short of danger. Danger. It's just like a red flashing light on our car's dashboard, which is actually signaling that do something. There's something wrong. So because it's tip of the iceberg, underlying anger, there are already emotions which are negative, intolerable emotions, which are basically waiting to be processed and waiting to be felt. Now, so having an anger is being human. We are not angel. Angel is all good, devil is all bad. Human being is a combination of good and bad. So we first of all, we have to acknowledge, we need to own it, that yes, being a human, we have anger, but having an anger is not a bad thing. But how you channelize it or how you react to that can be good or bad. So if you're Shahid Afridi, you will use that anger towards hitting a six against India, for example. Now there are certain ways of even receiving the anger. So we are talking about the interpersonal conflicts in the couples, for example. So there are 6 stages, and the first 3 stages of receiving the anger is listen, listen, and listen, and I will explain how. So in the first listen, if one person is angry, right, and he or she wants to say something, another person starts, yelling at him, the things get further wrong. Now, so what basically one of the technique is you do the first listening, and in the first listening, you're actually giving this message to the other person that he is a human being, and he has a right to be angry, being a human. Now then you ask him again that, can you repeat what you're saying? Can you repeat the story? Now when you do that, all of a sudden he started to feel that you are interested in his narrative, or you're interested in his story. And in the whole process, when you try to listen to it again for the third time, by that time you have actually slowed him down, and all of a sudden he soon starts to come from his emotional mind into his logical or rational mind, and then he starts to get some sense into the story, which probably he may or may not be wrong. Now, and then step four is like, you look at his plight, and, or give your view, and then reconciliation, or so whatever. So this how a little unprocessed anger can cause disruptions in the families, divorce, and all problems. Uh, Oops, okay, forgiveness. So again, this is a whole model, a whole concept. Just to touch base, two things on forgiveness. Now, this is also like a recent patient. So what happened that one of my patients, or rather two, because so they're locked. So because they're locked in, so what's happening that we are also saying that it's a kind of we are all in it together. You have to think of forgiving people, think of talking to people who have never talked before, picking up the phone and all. Now, so one person was really badly hurt by another person in his life, and he decided to forgive that person. And then after a couple of weeks, he came back to me and said to me, "The Dr. Naqvi, I'm so mad at myself, but now I'm also mad at the God, at the Jesus, that even though that person was rude to me and I took the generous path and I forgave him, even then I'm not at peace." Now, so, and this is a common experience. I think you guys also probably people would have come to you and said it. So let's examine why it is so. So the problem is that if you look developmentally, when as a human being, when the child is born, when the baby is born, our feelings or emotions basically start on the day one. We start to have feelings toward the mother, father, or caregiver, versus the speech. So the speech is delayed, phase delayed. There is a time lag between the birth of our emotion and the birth of our speech. The birth of the speech given to human being in about 1.5 or 2 years. So in other words, our feelings never had a chance to get recorded in the verbal language. Hence, they cannot be remembered in the verbal language, and therefore they cannot be forgotten or forgiven in the verbal language just by saying. And that's why they have to process and work it through to neurological terms. You can also say that they can process this whole feelings and the agreement of forgiveness from through frontal limbic pathways. So they have right now probably because maybe it's like they're cognitively saying that they're forgive, but they're not at their emotional limbic level, and that's why they're not uh, at peace. So we talked about the basic anxieties as a human being is that we don't like things which we cannot control, or at a set timing or set target, or we don't like things which are uncertain. Emotional dysregulation can just start like a fireball and can build up to become a snowball. And we need to again, let me give an example. If two people are fighting, the couples are fighting, and if you go, so there, you have two options. One is that you can start blaming, judging the other person, and go by your own statement or whatever, right? Now, in doing so, basically, you snowball into a situation when you have very close space of the other person listening to your argument, uh, because it's more it's not something that other person can see as an objective reality. So the other way is to and if you're also angry, you suddenly start to perform in a your suboptimal way, because probably you are not in yourself. Then your performance comes down like 80% or 70%, and that builds further resistance and resilience and back and forth. So this is one way. The other way is you stop the whole flow of the snowball, the momentum, by giving yourself a time and space at that time. Spend some time bearing that emotion that you are having, negative emotion, and sit with it, feel it, and then it will give you time that you will come back in a situation that you can reassess the reality, right? And when you reassess the reality, that can be the reality in hand for the other person to see as well, so that you can have a discussion, and then you can come to the combined judgment from different vantage point, and that will give you more entry points in your data. So more entry points, so that people can see what you are saying. That, so when you do that, and then the other person will see that you are listening to that person, or the other word is called emotive listening. The other person will see that you're listening to that person in an emotive way. That leads to the trust building, and whatever trust structures happen is going to build. वो हमारे जॉन एलिया साहब का शेर है कि एक ही तो हादसा है ये, और वो ये कि आज तक बात नहीं कही गई, बात नहीं सुनी गई. So there are a lot of problems which basically never got uh, said and never got contained or retained. Loneliness, quickly, people, the common problem loneliness. I think most common reason is people when they start to show their outer face or false self to people. They get up in the morning and meet with 100 people, and they hide their true self, and then at the end of the day they meet their true self, and which is lonely because they met with other people, all the human connectedness with their false self. So coming back to our whole process that what we are trying to do in this COVID-19. So with all this explanation, now our aim is to contain COVID-19, and it's important to know that what we can do individually and what we can basically help other people. For example, just one act of kindness, asking your elderly neighbor about the grocery. Some of my patients come up with this novel idea that all of a sudden they found that they have a time on their hand, and they can actually start writing old-fashioned letters with their pens, and they further went one step more, and they wrote the letters, and they actually read that letter on phone to their loved ones, and that basically enhanced the experience of both, mutual enhanced experience. Now, we are also challenging. Everybody is facing this challenge. I will just give you the U.S. data, pullback in the economy, and this is compounded by the financial crisis. There is a tendency, and we are expecting that the whole mental health storm is going to come and going to follow. So Theodore Roosevelt once said that the more you know about the past, the better that you can prepare yourself for the future. So by examining the behavior impact on the Great Recession and all the past pandemics, we can actually come up with a plan. So the global financial crisis in 2007 and 8, for example, and many countries saw that the higher rate of depression, anxieties, and both alcohol and drug use at that time. The Great Recession also had increase in the suicide rate, with unemployment with over causing 46,000 lives due to unemployment and income inequality in that year alone. Now, and we know that this, I think we already discussed about it, how COVID-19 is coming with this kind of a challenge for us. This is a recent study done by a private company, basically showing that people who are a low level of income, or they have like job losses or job reduction, had higher level of anxiety and depression versus the one who still have intact their job, and then they report drinking 1 out of 4, and illicit drugs 1 out of 7, and the prescription drug, which is right now here is a problem with prescription drugs, especially benzodiazepine. Opiates is trending down, but still, so 1 out of 5 reported taking prescription drugs for the first time. So the mental health problem, substance use problem, basically stem from the economic hardship, but they also are the drivers for low productivity. So, for example, WHO, according to WHO, depression and anxiety have an estimated cost to the global economy of $1 trillion per year in lost productivity. So This is recently announced for the mental health population. There were CARES Act, 425 million for a community-based behavioral health care and suicide prevention. Um, if you really, there is just a simplified way, one example that the cost to treat the diabetes of a patient with depression is on average almost $20,000 higher than for a patient without depression. Why? Because of so many things. Because the people who have mental health problems, they have problem in structuring their day. They have problem even transporting and commuting, and their own compliance with medication. So for every $1 spent on scaling up treatment for mental health disorder, a $4 return can be realized in improved health and productivity. Now, looking at the some of the countries, I try to get some studies outside the US as well. So in Italy, about 25% of the overall burden of disease is attributed to neuropsych disorders. And the Italian community based basically on psychiatric assistance and integrated into the national health system, including 183 mental health department and cares for almost 780,000 patients. And even now they're having online follow-ups. China, if you can see this study from Liu et al. Is a very high rate, especially Chinese medical workers. Prevalence rate of traumatic stress was at alarming rate of around 74%, depression 50. It's a very high rate, and general anxiety 44.7, insomnia 36.1. Now, special population, elderly, as they're basically at a double, it's like a double risk. One is that the way the coronavirus is behaving, it is not very good to the elderly. And if you see the studies from the Hong Kong and China from the SARS epidemic, you can see the major load of the mental health problem, including the deaths from suicide, was basically in the elderly population. There's all this study, and this is the one that I was telling about, like two factors basically stand out: disconnection and the fear of contracting SARS in elderly. But also, if you look at the bottom here, there was a high component. Oh, hang on, there were a high component that they harbored thoughts that they would become a burden and trouble their families. So what they did, they actually kill themselves as an altruistic motive, like kamikaze pilot in Japan historically. I will just quickly go through this. A recent poll in the US that showed that nearly half of the adults in the US reported that their mental health has been negatively impacted due to worry and stress over the virus. Isolation and job loss, additional feeling of anxiety, increasingly common, and people are fearful of themselves or loved ones feeling ill. And also, again, the way the virus is behaving, that even, you can be passing on the illness being asymptomatic. That's adding to the anxieties. And experience of loneliness is a public health problem. Now, of those sheltering in place, 21% reported major negative impact on their mental health from stress and worry about COVID, compared to 13% those are not sheltering in place. Similarly, those who are saying that their life have been disrupted a lot, which is 57%, or some, which is 44% by COVID, are more likely to report negative mental health impacts than those who say that their lives have only been disrupted a little bit or not at all. So this also highlights the fact that the level of threat perception, which is very important thing in overall management of your threat. That if you're high threshold or low threshold of threat perception, you end up using coping skills which are adaptive or maladaptive. That poll, I think it was just like 3 weeks ago it came out, and it also shows that the parents of the children under 18 are stressed out more mothers than the father. 57 women, and it is not showing here, but I think the study, so there is a 57 for women and 32 or 32.3 for men. But this shows that when they did their poll around two weeks prior, the number for women was 36. So you can see that there's a quick spike in the ratio of their problem with mental health. According to the most recent data from the Department of Labor, 5.2 million people filed unemployment benefit during the week of April 5th. So basically, becoming the whole month like 22 million. It's a huge number. It's a huge number because I mean, so historically, what happens that in Europe and US, any so we go by the suicide rate like per 100,000 of the population. Any change in unemployment rate, like a one point change, can give the one point uptick on the complete suicidal rate. And that's a huge thing. When I say one, it's not 0.1, it's one. So it's a huge impact. Like for example, in 2018, around 480,000 people in US died from suicide, and now people are estimating that it may be more than 54,000, 54 to 55,000. So that is a huge thing, which is basically in pipeline. This is pre-COVID data, so we'll just skip that. I don't know if you guys know about this famous book from Michael Lewis. We talk about the fifth risk. The fifth risk is the risk which you cannot see, you cannot perceive, but it's there, and it's you to ponder about what's the fifth risk. So, I mean, you can say anything as a fifth risk, but I think there are two fifth risks that I can see. One is the compassion fatigue, which means caregiver fatigue, that they get emotionally disengaged, which reduce their ability to provide care. So one is compassion fatigue. The other is the burnout for the healthcare worker or the first responder. So you can see the chronic physical emotional exhaustion, depreciation, feeling of inequity toward the caregiver relationship, irritability, weight loss, feeling of self-contempt, trouble sleeping, headaches, and also guilt and shame. Now, one thing I forgot to mention is that people, you have to be very careful. We just talked about the emotion of guilt and shame. The emotion of guilt and shame both are linked with an action component. So people, for example, who have a survivor guilt from their loved ones dying, they actually have these fantasies of rejoining, because remember I said that somebody is harboring the emotion of guilt. The movement is towards the people, right? Now, who the survivor guilt people, where are they going to go? That they want to join their loved ones, so they try to join them. So we have to be very careful in people who have survivor guilt, because they're very high risk of self-harm. So for people who have compassion fatigue and burnout, I think the best message is self-care is not being selfish. You really have to take some time off, and you really need to be kind to yourself, and it is okay to have some time off, and rather than being burnt out. You cannot be perfect. You can suspend your self-judgment and guilt to validate their emotions. Skip the PTSD, and this is the other thing. The strategies for us, for you, for me, for like first responder. Why? Meet the basic needs. And I think everybody has said it like too much. I just wanted to repeat that. Take breaks. Some people may feel guilty about that, they're not working full time, and you're taking time off. But believe me, that is important. Connect with your colleagues. Tell your story. Try to listen to their story, so that we can have the human connectedness, social connectedness. Communicate constructively. Be optimistic. Stay updated with the news, but try to limit your times, like 1 hour a day of the news, because you do not want to get into too much of sensation induced media. Complement each other. It's very powerful motivator and stress moderator. So share your frustrations and solutions and problem solving. And I think the rest of that are like self-explanatory. So with this being said, I think we come to the end of presentation, and I'm ready for the questions. Thank you.
Very interesting, and a different take. For now close to a month, we have been talking about the disease COVID-19 in terms of etiology, pathophysiology, diagnostic, and treatment management angles, this is a very important angle that we often forget. Um, and in physician burnout, even in the normal circumstances, pre-COVID, they have been talking about the physician burnout, especially in Pakistan. And it'll be interesting. I'll be very curious to know from our Pakistani colleagues how the situation is there in this particular aspect. But here in United States, even before COVID, for the past couple of years, this physician burnout has been a very hot topic, and the reason is that the model of the healthcare and the structure has been changing, or at least they're trying to change, um, and whenever there's uncertainty as to what will be the physician's role, what will be their what will be the impact on the physician, there will always be anxiety and physician burnout. So a lot of people who are close to retiring, first it was, the EMR, electronic medical record or electronic health record, that started somewhere in the past decade, around 2008, 2009. And a lot of physicians, I remember I started in 2008 getting the EMR. And I transitioned fine, although I was not that young either. But most of the older, close to retirement physicians, they just retired. They said, we don't know how to navigate the computers, and we are here to see patients. We are not here to run computers. And they continued the paper charts until they retired for a few years, because initially, obviously, the government was giving time to adapt to the new system. Same thing in the hospital. We used to have paper charts. So we go see patients in the hospital and then write on the paper our progress note. The initial consultation we used to dictate, but the follow-up notes we used to write on the paper. And then the hospital starts saying that no, you have to write it in the computer, in the electronic medical record. And then they said, you cannot order whatever you have to order on the computer and not on the paper. So that was, a struggle, a change, and physicians did not like it. But eventually, now, actually, in one of my hospital, there's no paper charts, and the other hospital announced that in the few months there will not be any paper charts, and 90% of the physicians are 95% are doing the online charting and orders. So these kind of, whenever there's a change, um, and then this model of reimbursement and fee for service is going out in favor of value-based care and population health. And nobody really knows, including the hospital leadership and the healthcare leadership, what does it really mean, and how will they gauge, and how will they implement the value-based care. So whenever the circumstances change for healthcare workers or the healthcare in itself, there will always be anxiety, depression, physician burnout. And now on top of that, this COVID-19, and there have been reports here also that the physicians who are employed with different corporations and hospitals and government, they are seeing some pay cuts. And the physicians who are self-employed and have their private practices have seen a tremendous decrease, at least 50%, if not more, in their practices. And so they have expenses, they have rents and utilities of their offices, as well as the payroll. And they have to let go of their employees, some of them, and it's hard in itself. Somebody's working for you and assisting you for, say, 10, 15 years, and suddenly you tell them that, no, they're not needed anymore because there are not enough patients. That in itself is a very depressing and shocking situation. So with all that, uh, pas manzar, I think Zafar's talk was really great, and I would like to invite the panelists to please introduce themselves, and then give their comments and questions for Zafar. So Shoaib Hassan, please introduce yourself.
Assalamu alaikum. Hello.
Ji, Shoaib.
Assalamu alaikum, sir. It's really nice to see the talk of Dr. Zafar and followed by your worthy comments. It's my good luck that being neurologist, I also being able to listen to such talk. Sir, the one I just want to have a comment and ask about your suggestions and your guidance that more in the current scenario, as this COVID has markedly affect our society, the thing which I am seeing in my practice is that the most of the people, the stigma is attached to the COVID-19. Anybody in Pakistan, what I am seeing is that if first of all the people, they don't get their testing done to be done, and if, for example, if they have been diagnosed or they have been COVID positive, the society takes them very take to them the task, and a stigma is attached to that person. uh, I just want to have the comment about how can we overcome this situation. Thanks, that's all, sir.
So,
So
Zafar, ji, you
yeah,
can take the question as they come.
yeah. So thank you very much. I think the two things, 2 points. One is so if you talk about the stigma versus the recommendation, the medical recommendations. Yes, I think it's very common here. Yeah, it is very common here as well. That somebody is being COVID positive, that they I mean, the thing is that it is even when you are going for the final rites for the death. Unfortunately, this is what's happening, and this is the medical necessity to save the life of the other person. So now I think that's something which is which is the reality, right? I mean, this is what we are all facing. Even the doctors are facing the challenge. I mean, even like deciding. I mean, fortunately not in US, but in Italy, and to deciding who's going to live and who's going to not, because it's kind of, as I mentioned in the very beginning, that the psychiatry or medicine, for example, in non-pandemic times and pandemic times. So the whole thing is changed, and we really want to, as a physician, as you know, that we want to save our lives of the patient. Now here we are not dealing with patient, we are dealing with patients. It's a community. So I think that's kind of a challenging situation. So but in a negative way, if somebody is putting it like a kind of a putting them down, so that has to be addressed at the communal level, at the level at large. But with this information, because I also see that, I don't know, you can tell me better, that in Pakistan people are still not following those like 6 feet distance and all these precautions. So I think that's something. uh, so for this stigma, information should be given, but with a side note that uh, keep on practicing the recommendations of social distancing.
Ji, thank you, Zafar. तो basically एक मैसेज जो जिस तरह जब हम by air सफर करते हैं, so we see that always that when the message come,
Yeah, the air hostess.
ऑक्सीजन, हाँ, जब
Yeah.
ऑक्सीजन मास्क
That's
जो
a good.
गिरेगा आपके मुंह के सामने, पहले आपने अपना
बताना
अपने मुंह पे डालना है
Yeah.
और फिर आपने किसी और के मुंह पे डालना है. That I find that message very, very helpful because that's what I tell my patients with dementia and Alzheimer's disease. And that's true for other chronic illnesses, but particularly dementia is very challenging in the sense that they totally forget how to take care of themselves. They become so dependent. They sometimes can be worse than children. So the people who are taking care of dementia patients, the caregiver of the dementia patient, they need respite care. They need a break because otherwise, if they are taking care of them day after month and years, they themselves get that fatigue, care fatigue, and they themselves get anxiety, depression, and other psychological illnesses and mental health illnesses. That's why it is very important. I tell them either you hire a paid employee to give you a break, but if you cannot afford and if you have family, you make a schedule how to take care of your loved one, mother or father. So next is Dr. Bushra Jamil. Please, Bushra, introduce yourself and comment and question.
Assalamu alaikum. I'm Bushra Jamil. I'm a professor at the Aga Khan University, and I really enjoyed your presentation. I've posted a question in chat as well, but somehow I feel that this pandemic has brought out the worst in all of us. Physicians and scientists are behaving in an odd manner because there is communications breakdown. Everyone is trying to do their own work, trying to find the answers individually, working in silos. Then there are patients who feel that they have to lie to get care at a hospital because if they reveal that they've tested COVID positive, they will not get the care they need, for example, for the chest pain or for their uncontrolled diabetes. And then there is aggression, which I've posted in. People at isolation centers are actually retaliating and trying to come up with very cunning strategies to get out of isolation centers. So I would like your comment on that.
Yeah, so I think it is again being human that goes down to our survival instinct, right? There was a study done in I think 30 years ago something. I forgot the name of the author. There was a study done, and it was an experiment which was they filled out they took a I forgot it's a duck or a bird something. So they put the mother bird or mother duck into the waterways, right? And they kept and with the baby bird, and they kept on filling the water, right? Now the mother bird, I mean, the mother is the number one protector, right? Number one, I mean, the mother is the most loving, like that loves the baby. So what was happening that the water was filling up, and the mother bird kept on saving the child and moving, basically try to keep it like up and up and up, and then finally when the level comes when her own breath got compromised, because water was filling up to the brim to the point, what did she do? That she threw the baby in the water and she jumped out of that. So that is kind of a survival instinct that at this point, this is what we are also fearing about, by the way. If you see that in February to March there were 3 million new weapons being brought in US. Yes, this is what I mean. Part of it is the nature, and part of it is depending upon their own psychological makeup and their personality structure. How do they manage these kind of anxiety? Because I think I mentioned in the answer to the first question is that it depends upon your own set perception, that how you like. There's the whole stress model for Lazarus. He basically said we go through the primary appraisal and secondary appraisal. So primary, when we perceive a threat, so first we gauge, okay, so this much is the threat, right? And what the injury has been done, what's the harm been done, and now what we could do. Then we come for secondary. In the secondary appraisal, we try to look for our resources, internal resources or external resources. Internal resources means level of motivation, level of strength and power, right? External resources, money or family, and then we come up with a plan and then we proceed accordingly. So I think it depends also on your own psychological makeup, your own ego reserves, that how you handle that situation. It varies from person to person, but yes, I understand what you're saying. Sometimes people are behaving in a very extreme way. Thank you.
Gee, so next is Farhan Kadir. Please, Farhan, unmute yourself and comment and question.
Assalamu alaikum ji, मेरा नाम फरहान है. I'm a nephrologist and a critical care physician. It was a really good talk, especially considering in ICU, we've been seeing a lot of depression, not in patients, but also the family members who cannot come and visit their family members. In terms of Pakistan, what I have noticed personally, that people are trying to hide their symptoms, not only to get the medical needs they need, but also they're hiding the symptoms so they're not thrown away from their regular jobs, and which could be a reason to spread. I guess there are so many other reasons for the psychological impact on these patients, patient families, in society. But I would say it was a great talk, considering as a critical care physician, where I don't think about psychological impact on patient families, which this disease, or in general the diseases, has on our patient and also on the patient family. But thank you very much for the talk. Thank you.
Thank you.
All right, so Fawzia, you're next. Please unmute yourself and introduce yourself and question and comment. Fawzia Kamal.
Ji, Assalamu alaikum. This is Fawzia Kamar. I'm an infectious disease physician at University of Massachusetts Medical School. And thank you very much for this talk. It was great listening to the other perspective besides just COVID. We are definitely seeing an increase in anxiety and as Dr. Naqvi mentioned, increase in domestic violence and other issues related behind it. It was just a comment that, you know, it's good to hear again about physician burnout, because that a lot of our physicians are working extra nowadays, and I'm sure that same is the case in Pakistan. And I'm not sure how physician burnout is dealt over there. I would be interested in knowing what our colleagues are doing over there to, you know, save and protect their other colleagues from physician burnout.
So we will ask more of the Pakistani colleagues once we introduce everybody.
Thank you.
Next, Mariam Motin, please introduce yourself. And Mariam.
Assalamu alaikum. This is Mariam Morton. I'm one of the cardiologists in California. I really liked the talk, and I was wondering if you could just comment on any specific recommendation to deal with the separation anxiety in this holy month of Ramadan due to inability to be around extended families. Will it lead to distancing among extended family in the future? Will it lead to frustration and anger or further isolation or defragmentation of families? How can we avoid that? And do you have any coping strategies for that? Thank you.
Thank you. Very good question. Let me give it, before that I will give an example. So you must have heard about the separation anxiety in kids, right? But we also, there are 5 separation anxieties in human development that we face. I mean, one of those separation anxieties is also when our kids start going to the schools. So nobody talks about that. So, and when there is also a departure from our norms, for example, we are so used to this, going to the religious congregations. Yes, so that's a common thing. But I think that the first of all, as I said, that if you can still emotionally connect with your masjid or your rituals, what you're doing, or with your loved ones, I think that will still give your mind a message that you still having some connection. So it's a physical distancing, not the social distancing. You can use through phone or Facebook or like FaceTime or apps. So that's one part of it. And then the second part of it is the it's so hopefully, I mean it is difficult to say unless there is a re-emergence of that but hopefully I think the place that we are right now, I don't think that it will extend to the next Ramadan. So I think that's a good hope. Now one thing, no sorry, but so when we're talking about hope, let me just tell you two things about hope. वो लोग कहते हैं खाली पीली की hope जो दे रहे हैं, तो let me just tell you, so yes, so there are two types of hopes. One is the cognitive hope, the other is instrumental or physical hope. So for example, if you have to help somebody and you say that सब ठीक हो जाएगा, everything will be okay, so that is a kind of वो जो जिस पे लोग जो comment करते हैं ये that जो बेकार की, it's a bad kind of a, so but the other way that you can do that, and which is actually a practical hope, because what I'm telling you that rather than saying that सब ठीक हो जाएगा, which is a cognitive hope, how about that? How about you do that? That try to operationalize this hope. How? I can ask you the question, and then you can keep asking yourself this question. That if you have a plan in July or August or September, whatever, right? And then you can start thinking on the baby steps that, okay, I'm just giving an example. For example, on Bakra Eid, right? You have to go somewhere. So just try to, in your mind, try to come up with some baby steps. Say that I will do this, I will do this, and then that will also help you distract from this current anxiety, and also the hope is going to further multiply into the future. So your hope will be projected in the future, and that will be a practical hope, not just a khali pili cognitive hope.
Good. So Mehreen Malik, you're next. Please introduce yourself and comment or question.
Assalamu alaikum. I'm Dr. Naheed, and I am working as an anesthesiologist at FAAN University Hospital, Karachi. So overall, I would like to talk about the mental health of the physicians. Overall, in Pakistan, unavailability of PPE, the risk of contracting infection and putting it on to your own family members and loved ones, and overall the pay cut because of lack of resources in Pakistan. It had created a very negative impact overall. But the young doctors, as I saw, they coped up pretty well, posting up different challenges. They created different small community groups to cope up with the mental health of doctors and people. Apps were created to cope up, to pep people up for the mental health. And I guess in our hospital, I would say the work schedule, 1 week on and 1 week off, was kind of a relief that we had some time at home as well. And then definitely research activities have been boosted up really enormously. Seeing this, that people are actually having time now to read and to deliberate and to think over. I think leaving the negativity behind and thinking of all the positive things that are coming up. Situation in Pakistan is overall not that bad as compared to other places. And doctors here are actually coping up pretty well. Seeing the scenario at other places, obviously we see on social media and get really depressed. But I think the general masses are the people who are actually affected, and they need to be pepped up, because people are actually hiding, even if they get corona positive, and if they're having symptoms, they're not coming up. They don't have the trust in doctors that they should come up to the hospital and surrender themselves to the healthcare authorities so that they can be isolated. And they do not have proper places where they can get isolated. So that fear is the main concern at the moment in Pakistan, that if you are positive, then what next? Is the police going to take you away? What is going to happen next? So that's one thing, the dilemma that we're facing right now. So if any good pointer of how we can build up trust with our patients and how we can, bring them forward to come up to the hospitals and help them out. That's my question.
Yeah, I think so. So I think that again, you're talking about two things. One is the local scenario that you have. That I think you as a leader, you're a leader of your team, and then your higher ups and all the leaders have to at higher level have to convey this message to the, for example, police authority. The one thing. The other thing is on your personal level. I think what I think I showed in the slide that what are the things that you need to do, and I think half of it you just did. You just did. So keep on doing that. That you keep on expressing, keep on talking about your feelings and emotions, your experiences over there with your colleagues, and in between that there are some solutions who basically working with you is going to come up locally. In that whole mix, when you talk about them, it will give you two purposes. One is that it will de-stress you, it will help you to navigate things, and then you can all of a sudden when there's so many people are talking which are your local colleagues, you will try to find new solution, and you can all of a sudden see and observe certain things which probably you are unaware of or you didn't see that.
Okay, I'm going to take one question from attendees. Dr. Hina Etazaz, I could not understand your question, so it's better if you can talk and ask yourself. I'm going to unmute you. Please unmute yourself and ask your question. Hina Etazaz. So, Hina Etazaz, are you there? If not, then I'll come back to our panelists. These are the raised hand. I forgot to introduce Shamsa Hamayu. Please introduce yourself and ask your question. Ji, Shamsa.
And Vice President, Society of Obstetricians and Gynecologists. Actually, I really enjoyed this talk. I want to ask one question from him that as I told you earlier कि हमारा जो hospital है, it is designated as COVID hospital for the pregnant ladies. तो मैं एक study plan कर रही थी. I just want his input कि ये जो -21 परफॉर्मा है, मैंने ये करना शुरू किया कि मेरे जितने रेजिडेंट फ्रंट लाइनर्स हैं, दोज हु आर लुकिंग आफ्टर सस्पेक्ट एंड कोविड पॉजिटिव पेशेंट्स, उनसे हम ये परफॉर्मा फिल करा रहे हैं. बिकॉज इनिशियली वंस इट वाज डिक्लेयर्ड द डेजिग्नेटेड हॉस्पिटल, ऑल जूनियर्स वर वेरी एंग्शियस, स्ट्रेस था, एंजाइटी थी, फिर एंग्री भी थे कि जी हमारी ड्यूटी क्यों लगा रहे हैं. सो जो रिस्पॉन्सेज होते हैं, रिएक्शंस होते हैं. So, but now they are settled down. Or so I thought के let's see के once they were sitting alone with in the COVID ward, what they were thinking और बाद में उनका क्या stress response था. तो कोई आप बताएंगे कोई this performer is okay या कोई और आपकी नजर में हो जो हम उनसे fill कराएं to find out.
I'm sorry, I'm not aware of this. क्या DEST 20, what is that? What does it stand for?
DASS DASS21, that is distress anxiety जो परफॉर्मा है, क्वेश्चनर है जो फिल कराते हैं हम.
अच्छा, उसके लिए जो होता है ना हैमिल्टन एंजाइटी, हेम डी और हेम ए के नाम से आता है, हैमिल्टन डिप्रेशन का और एंजाइटी. वो आई थिंक that's a better one for anxiety. I don't know. I'm sorry, the DASS21 क्या, I never used that.
Okay. Thank you.
Thank you.
Ji, Sohaib Hassan, you have another question. Go ahead. Ji, Sohaib. Unmute yourself and then ask your question.
Hello, sir. Can you hear me?
जी, बताइए.
सर मोस्टली जो हमारी न्यूरोलॉजिकल प्रैक्टिस में देखने में आ रहा है कि हमारे जो पेशेंट्स एंटी एपिलेप्टिक ड्रग्स पे या एंटी डिप्रेसेंट्स पे थे, उनको देयर इज अ सर्ज इन द इंक्रीज इन द फ्रीक्वेंसी ऑफ द सिम्टम्स. either that can be attributed to the COVID or this is due to the disease burden. एक तो सर ये कमेंट, इसके बारे में कमेंट चाहिए. एंड नेक्स्ट आई वुड आल्सो सेकंड मैडम शमसा his very nice suggestion that if such studies can be planned, if like her hospital is a designated one, and we can also have some like my hospital that can also have a such kind of studies in the healthcare professionals कि इसका जो psychological impact है उसको किया जाए. That is the comment, sir. Thank you.
Sorry, can I ask you a question? Which anti-epileptic you're talking about?
Sir, most of the drug, I am not single anti-epileptics. It's a general thing come into the observation that the patient on anti-epileptic drugs, they are having their increase of the symptoms. That is due to the anxiety, or that it's due to the disease.
So
Sir, can you hear me?
I can hear you, but so there is no study it's come out recently, or the reason I'm asking is because anti-seizure medication are also mood stabilizers. Are you talking about something like a Depakote or Tegretol or lithium? You're talking about those?
Yes, sir. Yes, sir.
So Depakote in particular, or so I think so. The answer basically because I think mostly because everybody is logged in, right? There are high emotionally charged exchanges and a high emotional exchange in the house, right? It can. So we are talking about biopsychosocials in psychiatry. Biological is a medication, and psychosocial aspect. So that psychosocial aspect of the psychiatry is basically totally marked because of this. So then, so I don't know what is the whole scenario of your patient. If it is something that you can check the levels, like lithium or Tegretol or Depakote, why not you do that and try to adjust it to a little bit slightly. For example, if you're going for 75 for Depakote, you can adjust it to 82 level to compensate for the psychosocial component.
Right. So I am going to take. I'll come to Dr. Maria Mothan later. I have three attendees who have posted questions, and I would like that they can ask themselves. So in order of this, Imjad Hussain, Mohammad Salim, and Shazmi Khan. I will come to you first. I'll go to Imjad Hussain and allow him to talk. I unmuted. Imjad, unmute yourself and please ask your question yourself.
Assalamualaikum. I'm Imjad Hussain from Pakistan, Jhang, and actually I'm a family physician with special interest in neuropsychiatry. And I had, first of all, thank you very much for this beautiful talk on the human aspect of COVID-19. And my first question was about, like I have been seeing patients with anxiety disorder, and for some reason, I just had one or two patients that were particularly having like they were not of general anxiety disorder. They were having this specific phobia of having coronavirus, and it's like they had they were thinking like they're going to die from it, something like that, of thanatophobia. So I was just wondering if there is something in the offing of a disorder or a phobia like that of a coronophobia. That was my first question. And do you want me to proceed with the other ones, or we'll do it one by one?
I can answer this one first. I mean, so you think that specifically when you say phobia, that's basically affecting that patient's daily life activities, education, work, the other like romantic life and work life. Is it affecting all three spheres?
It was, and I think her life was derailed. Like she was crying and she was sobbing, and it was like affecting. There was functional impairment for sure.
So do you think that it was also a subcomponent of because you said that she thought that she was dying, right? So that could be a subcomponent of the panic disorder. Was she choking because of that?
There were a lot of manifestations, so I was wondering if I may call it generalized anxiety disorder, but there was no past history of any like anxiety manifestation beforehand, and this all started in just 1 or 2 month period.
So her anxiety is like goes up and comes down like this, or it's a 24/7 background anxiety?
I think it was all the time, like she was wearing it out in the open.
I think, but there is in the future they may come up with. I think but I think you can, if you think diagnostically your clinical evaluation that it is a phobic disorder, then you can give the same treatment what we give for the phobic disorder.
Yeah, Thank you. So treatment is the same. I was just wondering, maybe we could call it something like a coronophobia, or it's just.
Well, you could call, but I think the treatment, so treatment is the same. It's both biological and psychosocial. So yeah, so you could give medication like SSRIs, depending upon, you know, there's so many other factors, you know, gender and age and other comorbidities, and then slow dose, very tiny dose, short time, 6 weeks or so, benzodiazepine if you can. But then but I think the major part is psychological. Then you can go for systemic desensitization, or basically you have see a therapist regularly. So yeah.
So I can proceed with the other question.
Yeah.
Actually, I have been seeing schizophrenic too, and in my practice, or it could be just my thing. I see that schizophrenic are a kind of immune, or they are not that much prone to what's going around them. And I was just wondering if it's just is there lack of insight into the disease, or we can attribute it to the kind of like they have deranged neurochemistry in their prefrontal cortex in other region, so they really don't appreciate the fear that much. So
yeah,
I just wanted your opinion on that.
It's a good question, and you are a neurologist. You will understand that there is some data, that the threat perception level of schizophrenic, because of two reasons. One is it depends, you know, if they're been you know, try to think that you have all these hallucinations all the time, right? Just try to be in the patient's shoes. And if somebody is having these kind of perceptions, right? Somebody is talking to you all the time, they have a problem. There is a mechanism called cocktail party phenomena. Cocktail party phenomena basically governs by the serotonin receptors. Is basically the ability for us to separate one voice from the another, and that basically governed by the serotonin receptors. So the people of schizophrenia, they lack this property of separating one voice for another, or screening out. So that can cause their low level of perception. That's one thing. The other thing is that there are some studies which also shows that they have some disconnection in pain perception, in a perception level in their or the speed by which they process any sensation. So that may be a component.
Yeah, sure. And my last question was, it's more of a philosophical implication, or maybe we can just, I think it's ingrained with psychiatry as well. So I was just wondering, in our society in Pakistan, we are an agrarian society, and we are not that much industrialized, and we have pretty laid back style in here. So I was just wondering, this disease, why this disease is having so much onslaught on the Western and industrialized nations, and in terms of psychological impacts, I was saying. And it's not there of a psychological threat for countries like us. Maybe it's because we just believe like whatever is going to happen will happen. We kind of like we're thinking what we have to lose.
I think it has, like, as you say, like too many factors, sub-factors, implications coming into play. I think part of it is also under-reporting in Pakistan, and again, our religion is a big strength. So there's and then so many other factors. You know, I think somebody was saying in the beginning that the shame and the stigma. So as I said, the shame takes you away from people, and for you to go to the doctor, you have to come out of shame, and then you will be engaged.
Okay, great. So I think we are way out of time, and I think in Pakistan people have to prepare for iftari as well. So the last 2 or 3 questions, Mohammed Salim is next, and I'm trying to see where I think Mohammed Salim might have left. His question was basically how we deal with this storm of psychiatric symptoms. I think that is a big, broad question. So if the time permits, then we can tackle at that time. But let me go to Shazmi Khan. Shazmi, please unmute yourself and ask your question directly.
Assalamu alaikum, Shahid and Dr. Zafar. It was very nice presentation. Actually, to me, it clear very first time that these all are spectrum of fear, starting from the anxiety all the way to the obsessive compulsive disorder. So thank you for a very nice presentation. My question is about like what I heard. This is what I'm, hearing, that you give, whether you call it cognitive or whether you call it real, you're giving a false hope, because we don't know. The countries who have actually started COVID, they long time, they came out of it. Are we gonna come out of it ever? In the Western world, in the North America, in Pakistan doesn't have such a big challenge. I'm working here in North America. I'm concerned, are we going to come out of it? Like, we should give a hope, such kind of hope which is actually have some feet in the ground, not suspending in the air. So do you have some solution for this kind of hopelessness and helplessness?
Yeah. So I think probably I was not able to explain myself better. I think what I was saying, and let me repeat what I said, is that hope can be a cognitive, like there are 5 types of hope, by the way. If you really want to go into detail, there are 5 varieties of hope. But to simplify, so one is the cognitive hope, and the other is more practical hope, right? Now, that brings us to another point. People are asking that the kids are, our children are asking questions, what should we basically give the answers to them? So the answer to that is that we really do not have to underreport them, we underinform them, or at the same time, we do not have to overinform them. Why? Because what happens that the kids have imaginative memories, right? They have imaginative power, which they can, if you under inform them, because they're hearing from here and there, so they will actually make a monster out of that. So they have these elaborative memories, and so that's one part. But if you over inform them, that can be too exciting and overwhelming for them. So you need to find a balance between what the reality is, give them the reality. So that is why the hope, you're right, I was not giving a false hope. What I was saying, that try to see, rather than thinking about that when, like, because nobody knows the time, right? Nobody knows about the time that when we are going to come out of that, right? So let's do those certain things which we can control. We cannot control the time. We can only control the things that we can do, the baby steps. So try to figure out that in September or October, whatever you do, try to get engaged in that and try to take those baby steps. That will give you some control, and by that's going to allay some anxieties as well.
Okay, good. So let me get back to the panelists one more time, and 3 have raised hand, and after that I'll ask others if they have a concluding remark or question. So let's go to Mariam Motin. Mariam, you had a question?
Assalamualaikum. I was wondering if you have any suggested coping mechanism that can be given to families and friends of those that are lost to COVID-19. And the other question that I have is have you noticed any difference in fear of being infected with COVID-19 different among different socioeconomic status?
So very interesting question. I think the first part is, I mean, unfortunately, because this is happening, that the final rights are basically, they are not having a closure. So we are going to get into a prolonged grief as well. And I also work with people who have a prolonged grief and pathological grief or bereavement. So there's certain things that we do for them. You can actually ask those family members who unfortunately didn't have a chance to attend the final rites of their loved ones.
I'm unmuted, nahi aa raha.
Hello? Can you hear me?
Yeah. Hello?
Can you hear me?
Yeah, this is Dr. Hina. Can you hear me?
Oh, so Dr. Hina, please wait.
Yeah, sure. Sorry, I just.
I'll talk.
Yeah.
I'll give you
Okay.
Yeah.
Okay.
So, yeah. So what I was saying, that there are certain things, people who have unresolved grief from their loved ones who basically passed away, and they never had a chance to have a closure to their, say bye to their loved ones. So certain technique like we can ask them to write a letter to the deceased and either put it to the river or somewhere, or put it in a ground or something, or bury them underground, because they never had a chance to see the body being buried. So that can cause, basically in their mind, they can have their psychological closure, because if they do not have a closure, then it will be a problem for them to move on from their, the chance that they may be stuck at that point of their life, because human beings, as basically by default, we really want to have closure of certain things at certain point. And yeah, just metaphorically, I mean, I don't know if it's a good example, it's like closing a chapter of a book and then starting a new chapter.
Thank you. Fawzia, you have a question, Fawzia Kamar?
Yes. So he touched a little bit on my question, but I wanted to know a little bit more in detail about how to deal this COVID phobia with our children. Children have so many questions. They have iPhones in their hands. They're Googling and finding out information. Information is flowing at the speed of light, I guess. It's just like coming from everywhere nowadays. So how to deal with their anxieties and how to address it safely so that I don't overdo it.
Yeah, so stepwise, what we are advising is, first of all, get some information from credible websites, WHO or Royal College of Psychiatrists or CDC, right? And get your facts right first, okay? And then depending upon the age of, because developmentally also it depends what developmental level they are. Because, for example, let me give you an example. Like if you're talking to a teenager, you can find out that the teenager is most angry at the point that why he or she is not able to help the family, right? So the anxieties are also age specific and changes with age. So you have to speak the language of that age to your child. So what we recommend, so get your facts first, then try to know what is their baseline. Okay, talk to them that what they already know about that, of this new coronavirus. And then, because you already have all the facts in your mind, you don't want them to be sort of listening to the media, which may be a wrong information, and then give them an honest answer which has both pros and cons. As I said, that because they have elaborative memories, they can actually make monster out of that. Or if they know already, you may lose your trust as a parent. And the other thing is that then they can be too much overwhelmed that, look, my parent is not telling me that detail, this means that there's something wrong. So that, but then you have to watch for one thing which very important. I'm telling the parents. So when you tell your children about certain things, right? And usually the response is that the anxieties are getting allayed. Their anxieties are getting extinguished or allayed. They're okay with your explanation. But if you find that your child is keep on asking about the same thing again and again and again and again without getting any change in the anxiety level, then that's a problem. That you probably you need to seek advice from mental health counselor, or maybe like there are some CBT techniques which are effective. So again, if by your repetitive explanation the child is not getting the proper anxiety element, the allaying of the anxiety, then it's good to see the mental health provider, because sometimes these anxieties can buy themselves, like either one anxiety can buy the another anxiety. So that's why you need to see how CBT in kids can help.
Okay, last one, I think, if others will not have any questions, is Dr. Hina. Had problem with the speaker before. Hina, you're unmuted. Please go ahead with your questions.
Well, okay. So first of all, I would like to tell you a situation in PIMS. I am a PG microbiology. And well, in PIMS, we hardly received any PPEs and, any N95 masks. So we were very scared, and we gathered some from YDA and stuff. And anyway, so we are very scared. So, then we take rotations, and, a number of doctors also got it infected. And I don't know if the government is also telling the right numbers. My question is how to deal with such a situation for a healthcare worker in which, I mean, the situation is very scary. But, you know, like we're talking about people, we're talking about everybody else. What about us? What about the healthcare workers who are the first line of defense? And I mean, don't they need any kind of psychotherapy? Shouldn't there be any centers where they can go and, you know, like something positive, you know, for them? They need moral support. They need, I mean, basically, if nothing else, then what could be what could be done for us? That's my question.
Thank you, Hina.
I think this is a question that you guys need to be asked at the local level. There are some hospitals, they have certain levels of kind of criteria. Like, for example, let me give an example here that we have a different standards for outpatient setting, inpatient setting, then rehab setting, you know, the drug rehab setting. And every hospital, they have their own policy. So try to find out what is their reasoning, and you know, as a collective, in a collective way with the doctors, and try to raise your voice and try to see what is. There has to be some method to the madness. So try to find out that.
So yeah, I think the different institution. I think Hina is right. PIMS and others. You know, there are different institutions in even Rawalpindi Institute of Urology. Got the funding from Pakistan, from Punjab government to buy these equipment, PPE and masks, but the in charge is afraid to order because he doesn't want to order a wrong mask and later on blamed for that it was not the right mask. So these are kind of, I would not say silly, but in that context, these are different issues. And of course, there's a local solution to that. But Hina, please keep trying. There are also the private organizations which are APPNA is one of them. If you can email me or somehow we can try to get to Rawalpindi. We have provided a lot of masks and PPEs from here and from China.
Yeah,
so,
and there is.
So we will do that. I think the Pakistan is very close to Iftar time, and I would like to be respectful of that.
Can I say one thing? I think there are also KN95, which are just like that. So that they also been used and they're effective, and I think they're also cheaper. So yeah.
Right, KN95 from China.
Yeah.
So with that, I think we will thank our speaker and panelists for great discussion, and have a nice and blessed Iftari and blessed Ramadan. Thank you. Assalamu alaikum.